Good morning. My name is Mary Yost, and I'm president of the Sage Group, LLC. Today, I'd like to talk to you about amputations, specifically major amputations, that is, above the knee and below the knee amputations that are performed for critical limb ischemia. By way of background, major amputations have declined over the last 15 years. However, we still have between 65 and 70,000 amputations performed annually for critical limb ischemia. 25% of CLI patients undergo amputation, and most importantly, major amputation is frequently the first and the only treatment that is given to these critical limb ischemia patients. This was demonstrated in a study that was published this year. Goodney and colleagues studied over 20,000 Medicare patients with critical limb ischemia who underwent amputation. Almost half of these patients had no angiogram done, and almost 3/4 had no revascularization procedure offered. This so-called pathway to amputation has not changed in over 30 years. The statistics are very similar to those found in the 1997 Hallett study, and the similar statistics were found in the 2005 Alley and colleagues study of Medicare patients. The probability of major amputation depends on who you are and where you live. In other words, the amputation lottery. Amputation varies by race, by age, by sex, socioeconomic status, hospital volume, and by geographic location. Medicare and Medicaid patients have more amputations than do those that are private pay, and Medicaid patients have the highest likelihood of an amputation. There are also significant geographic variations in vascular care prior to major amputation. In some locations in this country, patients receive many different procedures, diagnostic and revascularization. In other locations, they receive almost none. It has been shown that patients who have a diagnostic angiogram have a 90% less chance of undergoing an amputation. However, it has also been demonstrated that only 27% of hospitalized CLI patients in Medicare actually have had an angiogram performed. Major amputation is a costly procedure for the hospital, for the patient, as well as for the economy. Amputation is the 6th most expensive surgical procedure in this country. Now, who pays the bill? Medicare and Medicaid pay 83% of the bill. In other words, your tax dollars. Major amputation is associated with high mortality and high morbidity. Above the knee and below the knee amputations are 2 of the top 5 procedures with the highest in-hospital mortality. Below the knee amputation, 5 to 10% die in the hospital. Above the knee amputation, 15 to 20% die in the hospital. Morbidity is high. There's a 20 to 37% complication rate with amputation, and by way of comparison, general and vascular surgery, it's 16 to 17%. Revision rates are high. Below the knee, 20% need another amputation at a higher level. Above the knee, 12% need a second amputation at a higher level. These complications and mortality add significantly to the national economic costs of amputation. Major amputation is associated with very poor patient outcomes. 60 to 80% of these amputees cannot walk. Discharge status is poor. Less than 20% are discharged routinely to the home. Almost 3/4 need to go to another institution, either a nursing home, a rehab facility, or something like that. Depression occurs in up to 1/3 of these patients. There's also a high rate of hospital readmissions. Within 30 days, 22% need to be readmitted to the hospital, and within 1 year, almost 3/4 of these patients have to go back to the hospital for an amputation-related problem. At 2 years, 30 to 50% of these patients die, and frequently of a heart attack. So, as a researcher, I pose this question to you. Are patients and their families fully informed about the mortality and the complications associated with this procedure? There is some evidence that they aren't. If they were informed, would they acquiesce to an amputation without a second opinion, without demanding an angiogram, without requesting a revascularization attempt? I leave you with those questions. The previous discussion is an example of the type of research that we do. It is based on the peer-reviewed literature in amputation. Now, the SAGE Group is the leading research and consulting company that focuses on atherosclerotic diseases in the lower limbs. Specifically, we focus on peripheral artery disease, critical limb ischemia, acute limb ischemia, intermittent claudication, diabetic foot ulcers, and of course, amputation. For those of you who would like additional information about our research and consulting capabilities, we invite you to visit our website at www.thesagegroup.us. Thank you.